right, so we are on to our last talk of the day, and it's my pleasure to introduce Ashraf Naga, who will talk to us about evaluation and treatment of pediatric spine trauma.
Yeah, thank you so much. We'll try not to drag this too long so we don't get into the luau time. But we'll talk about the eval and treatment of the pediatric spine trauma patient. We'll talk about specific injury patterns that we see in this population, the initial management, operative indications, and sort of technical issues or technical considerations. These are my disclosures, none of which are relevant to this talk. And so we'll start off by talking about epidemiology and then highlighting the anatomic and biomechanical differences that make the pediatric and the growing spine different than the adult spine. And then we'll talk about the acute management, followed by pediatric-specific injury patterns, and then sort of our operative techniques and considerations. So in terms of spine trauma, pediatric patients account for 5 to 10% of all spine injuries, and 5% of all spinal cord injuries occur in the pediatric age group. The mortality in the young is actually higher, and we think that this is likely related to the higher degree of energy that's required to injure a more limber spine. And injuries are commonly missed. So in some series, injuries are missed at a rate of 50% on the initial exam, partly because kids are sometimes difficult historians. The mechanisms of injury, so despite advances in automotive engineering, the widespread sort of enforcement of drunk driving laws, the increased use of car seats and booster seats, motor vehicle collisions are still account for the majority of pediatric spine trauma. This is followed by falls, gunshot wounds, sports injuries. And then the other mechanisms that we can't neglect are non-accidental trauma. If this is missed and patients can have sort of devastating consequences the next time something happens. And in terms of birth trauma, there's usually an association with hyperextension on delivery or breech presentation. So within the pediatric group, there are differences between children and adolescents. So the mechanisms of injury in our adolescent group mirrors the adult population, whereas in children under 10, the falls account for a much greater percentage compared to the adolescent or adult population. And then there are also sort of there's differences in the distribution of injuries. So our younger children have a higher proportion of their injuries occur in the upper cervical spine. And this sort of takes us to the anatomic differences, especially in the young. So in our really young patients, their muscles are really underdeveloped or relatively underdeveloped. There's more ligamentous laxity. There's more motion at a particular motion segment, which makes the cervical spine a little bit more susceptible to injury. And there are larger head to neck ratios. The vertebral bodies are smaller, or they appear smaller on radiographs because we also have the non-ossified portions of the end plates, plus a very well hydrated disc, which allow for more motion. The facets are also shallower with a more horizontal orientation. So early in life, the facets are angled at 30 degrees as compared to 60 degrees in the adult. And what this leads to is more ability for horizontal translation. In terms of the biomechanics, the larger head to trunk ratio, most of the flexion the fulcrum happens at C2-3, sort of when we're very young. By age 5 or 6, this has sort of moved down to C5 or 6. And then with, a lot of times there are mimics of trauma, and so we have the ossification centers. And so understanding when these ossification centers fuse really is key to delineating normal findings on CT that may appear like fractures. The posterior arch fuses by age 3. This then fuses to the anterior body, usually by age 7, and the odontoid process is fused by age 7. And again, these growth centers are often mistaken for trauma. But sometimes there are injuries through these centers, so through the synchondrosis here in S2. So our pediatric spine trauma goals, our treatment goals are pretty simple, and you'll see variations of this slide throughout the next couple minutes. But our goal is to decompress what's compressed, to stabilize what's unstable, and to limit the effect of whatever intervention that we do on growth, on future growth and deformity. The acute management begins with a history and physical, understanding the mechanism, identifying, having a high suspicion, especially when there's loss of consciousness based on the history, when there's facial trauma, head trauma, or a patient is presenting as a polytrauma patient. And also, there are predisposing conditions. So in our patients with collagen disorders or those with conditions that lead to congenital cervical stenosis, in my mind, those patients have cervical spine injuries in the acute setting until proven otherwise. And then once we identified an injury in one portion of the spine, we're looking for non-contiguous injuries. The rates of non-contiguous injuries, depending on the series, is between like 8 and 15%. Our immobilization, because of the larger head-to-trunk ratio, there are specialized pediatric collars that are sized, and then pediatric boards that are recessed that allow the head to sit back in a more neutral position. If these are unavailable, you could simply build up your headboard under the torso so that you can maintain that alignment. If we inadvertently flex a patient in this setting, you can lead to kinking of the cord, which is unfortunate. Again, the neurologic exam is limited by patient's ability to our ability to elicit a good sensory exam or motor exam in our really young patients. So you're using all the tools at your disposal and have a threshold to get advanced imaging when your suspicion is high enough. There are several mimics of trauma. These are sort of the most common. So pseudosubluxation. We frequently see it sort of at C2, between C2 and C3. Here you see, looking at the anterior vertebral bodies, some anterior translation of C2 on C3. This can be seen in 9 to 22% of polytrauma patients, and it's not an injury. What's key here is the spinal laminar line, or points along C1, C2, and C3 are all in line with one another. If the spinal laminar point as C2 was anteriorly translated by more than 2 millimeters, you really suspect that this is a true injury and not pseudosubluxation. If we see these are in patients under 8, we're typically treating this with a closed reduction halo vest. Over 8 to 10, you start thinking more about stabilization. The synchondroses, we touched upon this earlier. A lot of time, sometimes our radiology colleagues would read these as injuries. If a patient has pain, it may warrant an MRI to evaluate whether there's actually edema, because sometimes injuries do happen in this area. The vertebral bodies may appear wedged in the young just because of the non-ossified components. And so again, these are not compression fractures. But if someone has a lot of pain or discomfort, then we can get some advanced imaging. So in terms of specific injury patterns, so while atlanto-occipital dissociations are not particular to pediatric patients, they can be very devastating, as they can be in the adult population. Mortality is directly linked to injury identification. In a series out of Seattle, patients who had this as a missed injury, there was a 50% in-hospital mortality rate. The issue is that these are rare injuries. And so anytime we see any asymmetry of the occipital condyle joint, you need to be really suspicious for an AOD. The neurologic exam in these patients is sometimes clouded by the fact that they may have concomitant traumatic brain injuries. And the treatment is universally surgical fixation. This is a patient of one of my adult patients. And it really highlights sort of the issues with like a poorly fitting collar. So with these injuries, distraction is a really big problem. And this is a patient who is appropriately placed in the collar. As you can see the shadow of the collar there in the ED. These are his initial injury scans. You can see the distraction between the occipital condyle and the C1. He subsequently went down for another head CT after I took him out of a collar. You can see that he's much better reduced. When I say we're taking him out of the collar, we're not immobilizing patients. These patients, I typically have them in, either sandbag or in either sandbag or IV bags placed on either side, taped to the bed. This has the added benefit of, everyone has, people are less likely to move the patient when they're sort of in this setup, which has an added benefit. Dens injuries, they're not uncommon in the young, especially under age 3. The injury can either be through the dens or through the synchondroses. Treatment is typically immobilization with a halo. If untreated, it may lead to an os odontodium, which if not recognized could be symptomatic later and need treatment subsequently. And then SCIWORA. So this was first described, so spinal cord injury without radiographic abnormalities, really well described in the early 80s. Defined as objective signs of myelopathy as a result of trauma in the absence of fracture or ligamentous instability on CT or radiographs, which were the imaging modalities at the time. In terms of the biomechanics, we think that the mechanism is a sort of a flexion extension mechanism where, given in a hypermobile spine, as this happens, the cord gets pinched between the anterior vertebral body of one and the adjacent posterior lamina of the adjacent vertebra. This accounts for about 6% of all pediatric spine trauma, and 80% of SCIWORA happens in patients less than 9 years old, though we certainly see these in our young adolescents and young adults. Several studies describe worsening neurologic function in about a quarter of patients that occurs in the first 4 days after injury, which warrants observation. We think that this is likely due to swelling of the cord after the initial trauma. The initial recommendations were for 12 weeks of bracing, but these have sort of, we'll talk about sort of when we can liberalize these. And in the current era, there's nearly universal MRIs for any pediatric patient who presents with trauma, at least in the West. So we've identified other injuries that weren't as readily identifiable in the time of just CT and radiographic evaluation. And so we see concomitant rupture of the ALL, PLL. Sometimes you see disc disruptions, injuries to the tectorial membrane in the upper cervical spine, and the like. So now with MRIs, we sort of categorize patients into there are 5 degrees of cord involvement. Patients with complete transections or major hemorrhage within the cord carry a very poor prognosis at 3 to 6 month follow-up. Patients who have a minor hemorrhage in the cord, 40% of those will improve to mild grades of cord injury at the 3 to 6 month mark. And then patients in whom they only have cord edema, 75% have improvement in their motor scores to a mild grade, and 25 will return to baseline. And in patients in whom there was no change seen in the cord, those all made a complete recovery in general. So in terms of the recommendation is for external immobilization of the spine for up to 12 weeks, given that it was the hypermobility that led to the injury. Any unstable injury that's identified on the MRI, of course, would be stabilized. But you can consider discontinuing the orthosis if a patient becomes asymptomatic and the spine is stable with flexion extension radiographs. There's level 3 evidence to avoid high-risk activities such as contact sports for 6 months following this injury. Our treatment goals, we'll touch upon those. In terms of technical considerations, when we're either treating someone in a halo or with surgery with halo placement, as compared to our adult populations, we're using more pins with less insertional torque, so typically 8 pins with 4 pounds. We're avoiding the nerves that we all know about and avoiding pins overlying the temporalis muscle due to the thin bone underneath. In terms of surgery, we typically don't do surgery in patients under the age of 12 under the age of 12 months because of difficulty attaining adequate fixation. By age 4, the pedicles have grown to the point where they can accommodate most small pedicle screw systems. But this requires a lot of preoperative planning and evaluation of the CT scan in particular. And what we're looking for, we're sort of weighing a couple different things. One is the size of the available osseous structures, the available bone that you're trying to instrument. You consider wiring techniques if the corridors are too small, depending also the implants that are available to you, and sort of the growth considerations. So in a very young patient, with a cervical spine injury that needs fixation, would favor more posteriorly based fixation to avoid tethering the anterior spine and resulting sort of cervical kyphosis. When instrumenting the upper cervical spine, the course of the vertebral artery needs to be well understood. So this involves either a CTA or MR imaging. Use a halo for head positioning as opposed to the Mayfield I typically use in the adult population just to get more pins holding the head. And of course, fiber optic intubation techniques for our unstable injuries. This is a great paper by Gekadal, who looked at CTs of patients aged 2 to 6, and they identified that the occipital keel, the C1 lateral mass, and the C2 lamina all offered adequate space for screw placement in almost all cases. The pedicles were considered safe, meaning that they could accommodate a 4mm screw in only 50% of pedicles. Sometimes there were asymmetries, so this needs to be investigated beforehand. And the C1, C2 transarticular pathway was only feasible in 4% at this age. In terms of thoracolumbar trauma, Apophyseal ring injuries are really particular to our adolescent population. They can mimic a disc herniation. On CT, they may appear as like a very small fragment, but the soft tissue components may be larger than what the CT would imply. And these can benefit from decompression if there are sort of these similar symptoms that we would see from an acute disc herniation, similar indications. In terms of the injuries that that we see more often in the thoracolumbar spine, in terms of our axial injuries, our compression fractures and our burst fractures, our compression fractures are all treated with pain control. We don't really have the same issues that we have in our geriatric populations with osteopenia, osteoporosis. Our burst fractures are generally non-operative in the absence of neurologic compression, but then we'll consider surgery if there's ongoing compression or if there's significant kyphosis on the uprights. The question then becomes if you're instrumenting to do it with or without a fusion. I think with kids, I tend to forego a fusion with relying on the bone healing and considering a hardware removal later. Our chance type variant fractures are lap belt injuries. These are flexion distraction injuries that we saw more so in the 1950s after the advent of lap belts, or when a child is wearing sort of a seat belt that rides over their belly as opposed to the ASIS. And this is sort of the rationale for the booster seats that have become more commonplace. And so these injuries lead to our chance variant fractures with distraction posteriorly. These can, if the bony component of these heals, then you don't really need a fusion. So you can consider hyperextension bracing. But more recently, we've moved more to percutaneous fixation with hardware removal once the fracture heals at the 6 to 9 month mark. So in summary, our pediatric spine injury patterns are related. The injuries that we see are related to the particular anatomy and biomechanics of the growing spine. A thorough examination and high suspicion following injury is imperative to avoid really missed injuries. We need to understand the age-related anatomy and the ossification centers and when they close. And our goals are, again, to decompress what's compressed, to stabilize what's unstable, and to limit growth disturbances. And operative intervention requires careful planning and consideration of the available bony corridors. So, thank you.
We have time for a couple quick questions, and then we will adjourn for our picture downstairs. We'll just go down the 2 escalators. The picture will be right there in the lobby. Questions? I guess I'll start with one. I agree with your approach for thoracolumbar burst fractures. I try to treat them non-op. I've certainly had a few that in follow-up or even discharge films are falling closer, into kyphosis. So I do. I've moved to percutaneous instrumentation for those.
Yep.
With that kind of critical decision, do you fuse? Do you plan to take out the instrumentation?
Yeah.
And I think one thing that guides me a little bit is the integrity of the end plate, and whether that is disrupted. I look closely at the facets, but any other things that you think about when you're deciding whether to fuse or not?
Yeah, I think the question for me happens a lot with like the chance fractures in particular. And there's a spectrum in terms of the chance fractures. Is it mostly a bony chance or is it mostly ligamentous? There really isn't much data as to when to fuse, but I think for our mostly ligamentous ones, I tend to consider fusion, at least in the adult population. In the pediatric population, I would still probably consider not fusing because, if that fails, the subsequent treatment would still be a fusion across the same motion segment, so it doesn't make the later surgery more difficult, or you don't need necessarily more segments.
Yeah, along those lines, I know we think alike a lot of those, and I've been doing a lot more perc as well and taking them out later. What do you look for on your 6 to 9 month CT to see when it's okay to take those screws out?
Yeah, so for a burst fracture, if the anterior vertebral body looks like it's just one segment without a fracture line going through. But really, it's also the resolution of their pain and discomfort. So I think the two sort of go hand in hand. For the adults, I usually wait a little bit longer just because I think that kids heal a lot quicker. So I'm usually ordering the CT at the 6 month mark and then seeing them at the, in our system, it takes some time to get them. And so I'm usually setting them up for an appointment at the 9 month mark. And so it's usually closer to 9 months. And if someone has risk factors, I might just wait, because the downside of waiting, especially in our adult population, is the screws may loosen or the rods may break. And there really isn't much consequence if the plan was to take it out because you didn't fuse. So.